I'm great. So I'm Dr. Sonia Jarrett. I'm one of the Pediatric Emergency Medicine Fellows. I did my training in pediatrics before my fellowship, and I am based in Boston. I'm very excited to be here with you virtually and hope to contribute to the conversation.
Good afternoon, everyone. My name is Anna Kaguna. I am an emergency medicine resident in my second year at Macquarie. I'm glad to be here. Thank you.
Thank you so much for those introductions, and we welcome all our experts to this session. And we are delighted and privileged to have this session in Mbarara once again. And we have the best experts in the country. Right now, there is a pretest that is going to be posted. Please let us all fill the question and we submit in time. Okay, just keep checking as we continue with the session. Right now, as we dive into our session today, whose title is Approach to Adult and Pediatric Death in Airway and Difficult in Breathing, we are going to have a case presentation by Dr. Anna, as we shall see other parts of the session. Thank you. Dr. Anna, you're welcome.
Thank you.
For the first presentation.
Okay, unmuted.
Yes, Dr. Anna, you're welcome to give us the case presentation.
Okay, good afternoon, everyone, once again. My name is Anna, and I'll be doing the case presentation. I am presenting the demographics of our patient. So I'm presenting NX, a 9-month-old infant who was male, Catholic, who came to the hospital on the 12th of October at about 8:30 p.m. And unfortunately, we lost him on the 13th of October at about 1 a.m. He presented with a 3 days history of a fever, difficulty in breathing, and a cough. History of presenting complaint. He was a 9-month-old infant who was well till 3 days prior to admission when he developed an irritating cough that was associated with difficulty in breathing, noisy breathing. Characteristically, it was a stridor, and there was increased work of breathing that worsened over time. Notably, also in history, he had high-grade fevers that were intermittent in nature, but for the 3 days prior to admission, there was no history of convulsions, no history of drenching night sweat, and no history of remarkable weight loss reported by the parent. the mother had been using herbal medicine for the 3 days when the child fell sick by famous traditionalists near by their home, and she reported that the reason she brought the child to hospital was because the child wasn't improving over time. So on examination, review of other systems, they were unremarkable. All other systems, there was nothing significant to note. Past medical history, this was a second admission. The first being when the child was about 7 months old, when he was treated for severe pneumonia at that time. The mother reported no known chronic illnesses, no allergies that the child had been having. No history of surgeries, no blood transfusions from the time the child was born. Family social history, he was staying with both parents. The mother was a waitress, the father a businessman, and reported no known familial chronic illnesses. The antenatal history was unremarkable. The mother had 4 antenatal visits and the pregnancy was uneventful. He was delivered at term. A birth weight was 3 kilograms and cried immediately after birth. No history of admission to the NICU or any events in the perinatal period. Immunization, the child was immunized up to about 6 months and up to 3 months, and then the 6-month stage wasn't given because the child was sick at that time. And at the time of admission, he hadn't also gotten the immunization at 9 months. Growth and development has been unremarkable. Had a social smile at the 6 week, sat at 4 months, at 6 months started crawling, and at 9 months was standing up. On examination, it was a sick-looking infant crying inconsolably in severe respiratory distress, was febrile to touch, and the temperature was 39.5 degrees Celsius. Child was not pale, was not jaundiced, was not dehydrated, and was not cyanosed at the time of admission. Primary survey, the air was patent, but it was threatened in view of the noisy breathing and the stridor. So it was a potential of threatened to obstruction. Breathing, the respiratory rate was 55, which was a little bit high for the age. The saturation was 74% on room air. He had a noisy breathing. There was a stridor and was in severe respiratory distress with severe subcostal recession. Had equal chest movements. There was equal air entry at admission, and there was an inspiratory stridor that was hard. The saturation, he was warm. Cup refill was less than 3 seconds. The heart rate was 132. The heart sounds 1 and 2 were hard and normal, and there were no added sounds. Disability, at time of admission, he was alert, but he convulsed at that time. And it was a generalized tonic-clonic convulsion that lasted about 3 minutes. There was no loss of consciousness post-ictal, and there were no focal neurological deficits noted at initial examination. On exposure, the temperature was 39, and notably, he had a swollen upper lip. However, there was no rash noted elsewhere or any swelling noted anywhere on the body. Secondary exam, apart from the respiratory exam, there was no other system that was significant initially. So at that time, we had a problem list with fevers, convulsions, severe respiratory distress, and the child was hypoxic. So our differential diagnosis at that time was severe viral croup, and the differential diagnoses were anaphylaxis in view of the swollen lip, history of a herbal medicine use, and then the stridor. We thought about severe pneumonia in view of the severe subcostal recession, the fevers, and the history of a cough, and the hypoxia. And then we also thought about a foreign body aspiration in view of the stridor. So at that time, 8:40 p.m., we intervened. When the child convulsed, we gave a dose of diazepam at 2.5 milligrams start. We gave rectal paracetamol for the fevers, gave a bolus of IV D10. We could not measure the RBS, but we just gave D10 of 40 ml start. nebulized with adrenaline, 1 in 1,000. We gave 2 meals. We nebulized under oxygen, and then we gave IV ceftriaxone. Reassessed the child later at 10 p.m. and child was notably still in distress. There was still an audible stridor, still the fevers, however, had subsided and the child had not convulsed again. At this point, we nebulized with videnoside 0.5 ml stat. We changed oxygen therapy to CPAP, and then we started preparing for a definitive airway. We got our ETTs, got the laryngoscope, and prepared for a potential intubation for this child. At 12 a.m., the child developed grasping respirations. There was no pulse, and we declared a cardiac arrest at that time, started CPR, and we got ROSC after 15 minutes. We gave intravenous adrenaline in between the CPR sessions at a rate of 0.05 milligrams per kg. We informed ICU about our intention to admit the child to ICU for a respiratory failure. Yes, but we took a mechanical ventilation area, so we had to transfer the child to ICU. But in the meantime, as we ventilated, we kept ventilating using an ambu bag, and as we waited for the logistics to transfer the child to ICU. Unfortunately, at 1 a.m., we got a second cardiac arrest, and this time the CPR was futile, and after 20 minutes, we called it off and we confirmed death at about 1:20 a.m. So in summary, presented a 9-month-old infant who was admitted with 3 days history of dry irritating cough that was associated with high-grade intermittent fevers and difficulty in breathing. He had 1 episode of generalized tonic-clonic convulsion at admission with no loss of consciousness in the post-ictal period. Exam findings notably, it was a sick infant who was in severe respiratory distress with noisy breathing, characteristically a stridor, and he was hypoxic with a SAT of 77% on room air and was tachypnic with a respiratory rate of 55 beats per minute. Yes, that's my case in summary. We can welcome the questions and yes.
Thanks so much, Dr. Anna, for that case presentation. It was quite elaborative, and thanks for taking the time to get all the events that happened in that case. Right now, I would wish to interact with the experts about this case scenario, and to Sylvia, I would wish to ask you, for you, what stood out in this case for you as a person?
Me, this patient, if I was the one, let's say, on the ED, I would think about the management and examination of this patient, too critical, because we see that patient came in a typical red category. It was an obvious triage category, so I expected I would do triage as quick as I can, because the patient had really the quick and the indicators of the red category. The patient came in distress, the patient had a stridor, which obviously would tell me that this patient really needs quick assessment. And I would make sure that I move the patient right to the resus room, and I start my assessment and intervention quickly in about less than 10 minutes. In about 3-4 minutes, I would have started maintaining and securing the airway, tackling the breathing. I see the patient came in distress, so I would think about taking the circulation, which we see it was about 75, and I look for the ways how best I can manage and which level of mechanism should I give the oxygen. Then you go ahead, and I was to be some quick and good management interventions for this patient, so that in about 30 minutes we be doing. But I see they tried their best, and in their quick and fast initiation, it was kind of delayed because it took about 10 minutes. The patient came in at around 8:30, and the first initial treatment was at 8:40, which about almost 10 minutes, and the patient had really typical things that would show you the patient needed treatment and management in the first about 2 to 3 minutes of the presentation of the AD. Thank you.
Thank you, Madam Sylvia, for noting that. Dr. Sonia, what are the key things you would have wanted people to notice while assessing this child?
Yes, thank you, everyone. And thank you, Dr. Kaguna, for this case, although it is very sad. I agree with everything that Sylvia just mentioned, that the most important thing for any patient, I'm sure that you would agree, is like airway, breathing, circulation. First thing is just ABC to, make sure the patient is safe with their respiratory status. But that's just the general emergency care. To provide some pediatric side specific points, I think it's important to consider, the very beginning, this patient was coming in with fever. Often in children, their respiratory status can look much worse when they have fever. So it would be also important to consider giving some medication to help bring the fever down. That is not going to change the ultimate outcome, but if you have a patient that is generally, stable and has a fever, you would consider to give some paracetamol to help maybe with the work of breathing. In children, you also want to consider stridor. Is it with rest or is it with distress? In this patient, I'm not sure which one he had. It sounds like probably he had stridor at rest, but that is more serious and dangerous, suggesting a threatened airway compared to stridor with agitation. So if you had a patient who came in like this, you definitely want to get them in the resuscitation room immediately to initiate the nebulized adrenaline like they already did. If the patient is a child that has stridor only with agitation, then it's very important to help keep them calm. For example, you may want the parent to hold them to keep them happy. You may not want to start doing, cannulas or blood tests before to make sure that they don't get agitated and make the stridor worse. So that's one pediatric specific thing to keep the patient happy if they have stridor with agitation. And so those are kind of the things that I'm thinking about as well. I think the last point just to make, and I'm happy to answer more questions, this patient, I believe, had not had all his immunizations. So that is important to think about for infectious causes as well.
Thank you, Dr. Sonia, for that contribution. For Dr. Linga, what would be some of the differential diagnoses you think of this case?
All right, thank you very much, Anne, for that detailed history and examination. So in an emergency, you want to keep your differential diagnosis as broad as possible so that you don't hit a dead end. And you rank them according to what is going to kill my patient first. So your child has come into the department and is having noisy breathing, like you had said. So you're thinking this is an infant of that age. So one foreign body would have been in that airway and it's lodged there. Now we're having noisy breathing. Like doctors just talked about immunization. You think about epiglottitis, because this is also going to affect your management. If you disturb the child further, epiglottis closes the airway and also accessing during intubation becomes difficult. In our settings, yes, most of these children are taken to clinics here and there, so anaphylaxis comes in handy. You don't know what antibiotic, and could this be the first time this child was getting? So anaphylaxis becomes another differential. We can then have others like pneumonia. Then characterizing the noisy breathing, yes, you say it's stridor, but you can have a child coming in with barking cough and thinking of a possible viral flu. Then you keep ranking them according to really what is going to give your patient first.
Thank you, Dr. Lisa, for that. Dr. Andrew, how can you differentiate between a group and a stridor? Now, setting.
So as far as differentiating the different causes of stridor in a child, I think Dr. Olinga kind of brought some of these up. So if a child has a very sudden onset in stridor and wasn't sick beforehand, I have foreign body very high on my list. If there's sort of a viral prodrome, like they've had maybe cough, fevers for a couple days first, then we might think about croup, but we should also think about epiglottitis, especially in an unimmunized child, which I think in this case the kid was, so I would have that on my list as well. And I think someone on the chat brought up whether like a oropharyngeal exam was done. I think that's important too, because you're also looking for things like angioedema, which is like swelling of the tongue, lips, potentially even the epiglottis. So I think that exam also becomes very important. And then you're also looking for maybe infection in the submandibular space, which could be like we call it Ludwig's angina, but it's like an abscess below the tongue. Could also, I assume if the child had any of those obvious swellings, you would have reported it in the case, but just a good thing to think about and point out. So the course of the case and the exam really point me towards those different diagnoses. If it's croup, I would think more like that bark-like cough that Dr. Olinga was talking about. That would point me more that way. But croup typically doesn't get rapidly worse and end up with the patient coding. That would make me think more epiglottitis. If the airway exam is just getting worse and worse right in front of you, then it's epiglottitis until proven otherwise.
Thank you so much, Mr. Andrew, for that elaboration too. Now we come to Dr. Anna. Having known the outcome retrospectively, what other steps do you think should be taken next time in the management of this session?
Thank you everyone for the input. Yes, my audible enough? Okay, so as saying, thank you everyone. Considering the case and then looking at it retrospectively, I would think maybe I would have considered giving a parenteral steroid rather than the inhaled, the budesonide. It could have helped with the airway edema that this child could have been having at that time. I think most likely the dexamethasone. It would have been a better option than the budesonide that we gave, given the child was not improving over time. And then possibly we should have intubated earlier. The only challenge is usually it's a system. You intubate, you have to make sure you get a vent immediately. But possibly if we had intubated at a time when after our first nebulization and secured the airway early enough, maybe let this child rest, like Dr. Sonia had said, because it was an agitated child. It could have been a better way to handle this child than how we went through, but at some point it was system problems. Yes, but that's what I think we could have done better for this child. Early airway intervention for the child would have been the best.
Thank you, Dr. Anna, for that. Maybe to Dr. Krista, what other interventions or medications could have been added in this case?
I think I thank you, Sister Charity, for the question, and Anna for the preparation for the case. Very interesting case and very common. And just as an aside, we've received a patient before, an adult with a stridor that we basically just disturbed and coded on us while we took them to the CT for resuscitation, for a CT scan of the chest. So it's not just pediatrics that would not start, but just general either you want to handle them with care, you don't want to distort their peace, because that could drive them quickly into a respiratory arrest and eventually into a cardiac arrest. So for this case, I agree with all the discussion points regarding the management, the addition of a steroid, particularly Dexa or prednisone, as an addition to this patient's treatment, and then nebulizing with some epinephrine, currently using oxygen, but in the hands of the mother. So the mother is the one to actually hold the whole nebulizing mask so that the child is not afraid or anxious. So for me, I feel that Dr. Anna and team actually did their best with the case, and sounds like the child was very sick. A respiratory rate of 55 is quite high, and yeah, so that's what I would add: oxygen and nebulization and Dexa.
Okay, thanks so much, Dr. Vista, for that contribution. And I thank all the experts for the contribution. Right now, once again, I welcome all those on the staff just wrote today, and all other regional referral hospitals, private facilities, and all other individuals that have logged in. Welcome you once again. And at this moment, we would wish to ask the participants, you can put it on the chat, your questions, which we shall answer later. If there are any other thoughts about this case, please type in the chat, and the experts will be able to handle the questions as we go on. The pretest is already protected. Please, I encourage all the participants, please, let's access the pretest, and we'll be able to answer the questions and we submit as we go on. Thank you. Right now, I welcome Dr. Priska Chizito to present to us the assessment and signs and symptoms of the threatened airway and difficulty breathing. Dr. Priska, you're welcome.
Thank you so much, Sister Charity. So at this point, we shall review airway management, airway and breathing. And just as an overview, we shall be looking at the function of the airway and breathing circuits, basically. Now for this, the anatomy in lay terms, what they look like, and where they span from, where we start and where we end, to call it an airway, upper or lower. And then we shall look at a few things regarding the assessment of the airway, assessment of breathing, and lastly, what we need to intervene in terms of airway management and breathing specific conditions. So, as regards to the airway, I think this is familiar to all of us. You know that if you are alive, you need oxygen and you need to put out carbon dioxide. So the role of the airway is to actually conduct the exchange of those two substances, oxygen in and carbon dioxide out, which is oxygenation versus ventilation out of your body. And basically starts at your nasal cavity and goes down to the oral and then nasopharynx, to the larynx, which has several cartilaginous parts, which we could actually, we feel in our next part of that. And then down to the lower respiratory tract, which has again a cartilaginous part, the trachea, down to the bronchi. We have the main right and left main bronchi, which split into several smaller bronchi that make up the smaller airways, in addition to the alveoli. So in simple terms, your airway is divided into the upper, which we can all see basically above the neck or above the larynx internally, is your upper airway. And if you go lower than that, then you're going down to the lower airway, which is the trachea, down to the alveoli. And in terms of so we talked about this. This is just to elaborate some more in terms of your airway. And any of these parts could actually be infected, it could get swollen. So Dr. Andrew talked about something like angioedema, which is just some sort of allergic reaction that causes swelling. So any of these bits could actually get swollen or get damaged or get something to obstruct your airway and lead to things like stridors, we shall see ahead. While in the lower airway, up here, just like I said, we conduct exchange of gases. That's oxygen in to lead to oxygenation, and the exchange of carbon dioxide out to lead to ventilation. All those things have to be in a certain balance, which is what your airway helps us do. So down here we have the trachea. So from where your neck is, the thyroid cartilage is one of the, for men, it's the, what's the letter? Adam's apple. Adam's apple. So that helps you identify where your lower airway is actually starting. And below that, you have your right and left main bronchi, here and there, and splitting into the smaller bronchioles, and eventually those give you the air sacs, which are the alveoli where the basic exchange takes place. So there are, besides what we can see here on this image, there are other parts of the body that are actually involved in airway and breathing management. And if any of these things are actually distorted, you might have a patient not obviously having swelling in what you obviously see as the mouth or nose or throat, but they're actually having difficulties in maintaining their airway or actually breathing system. So here we have the brainstem, which is down in your medulla oblongata from layman's science. And that helps in stimulating both inspiration and expiration based on your oxygen and carbon dioxide levels. And we have the spinal cord and the vagal and phrenic nerves. Like any part of your body, you need some nervous innervation to be able to enable your diaphragm to flatten or dome up, to form that dome shape, to be able to push out some air or inhale. And then you also need the chest wall and something we call the bucket handle mechanism, to breathe in and out, allow that expansion and exchange of air. And finally, you need your cardiovascular system. Everything needs cardiovascular system. If any of those parts has any inflammation, maybe from infection or trauma, swelling, tumors, and that leads to any distortion of that anatomy, then we have airway obstruction. And of course, if your airway is obstructed, even your breathing and gaseous exchange is going to be disturbed in the long run. So that's briefly what the function and a setup of your upper and lower airway should be like. So we go ahead to assessing breathing, airway and breathing. And this I normally summarize in just 3 phrases: look, listen, and feel, okay? And looking starts from you entering a room. So as Ali down in the audience walked in, I don't know if you noticed whether I was breathing or not, but you should start at the door of the hospital to look around for someone with airway problems, because they might be in what we call a tripod position, sitting up and leaning forward, or they appear like they're choking, and that is just their coughing, they're trying to clear up and holding up their neck, try and push out something themselves. And then if they don't have that, for you to confirm that their airway is open, you have to start by greeting your patient if they are awake. Hello, sir, what's your name? If they respond, then that's usually a good sign that their airway is open. And of course, that's looking. Then as you listen, you want to listen for the breath. We said your airway starts at the nose. So you're listening to the breath. We shall have some demonstrations. You're listening to their voice. If it's muffled, muffled means hot potato, like you've eaten something hot and it fails to go down your throat. So, so hoarse or muffled. And then you're listening to whether words are actually coming out in beats. You know, they can't complete. And that could be a sign of both upper, but also lower airway obstruction. And we talked about stridor as a key characteristic. Wheezing is another thing you can listen to before you even touch your patient. So you go down to visually inspecting, which is now the feel that we talked about. So look, open the patient's mouth, look for that swelling. Our child in that case had upper lip swelling, which stirred up some thoughts of anaphylaxis. So that's already telling you inflammation is taking place. So look for swellings, look for foreign bodies. Is it the tongue falling back? And if their posture, if they are lying back, that's most probably the cause of airway obstruction. And of course, the obvious things are secretions like blood or mucoid secretions coming out. The other thing I didn't talk about is what we call gargling. When someone has secretions, the sound that they'll make is like you're taking something with a straw, like at the end when the fluid is left, and now they are doing something like gargling. And then snoring. Some people call it stutter. So snoring is also another sign of airway obstruction, and usually it's as simple as positioning that's missing. And of course, you'll see some obvious things. Maybe they have a broken jaw as you inspect. So you have to look and feel that their jaw and they are able to close their mouth very well. So after you've looked at the upper part, you're now going down to assessing your breathing compartment, which is mostly your chest. So you're looking at the work of breathing, and here you're looking at signs of respiratory distress. So you're counting the rate. We shall see pediatric, but in the adults, we expect the respiratory rate to be counted for a minute. Whether you're young or old, the ideal is to be counted for a minute, and it should range between 12 and 20. So if anything is beyond or below that, then you have question marks on your patient's breathing problems, what is causing it. And then check if they're actually using accessory muscles. Both pediatric and adults can use accessory muscles. So I'll focus on our adults here. The abdominal muscles are accessory muscles. So if someone is working hard and you're seeing their tongue going in hard, that's already telling you that. And then if they are these muscles, the sternocleidomastoids, neck muscles, are stretching really hard, or they are nasal flaring, or they are head bobbing, then you're already thinking this patient is actually working really hard to breathe. And then we also want to rule out the volume of breathing. Okay, they are breathing at a rate of 14, but is it what you expect them to do? Is it too deep? Is it too shallow? So you want to check out the volume of breathing, and in that way you might actually wonder whether your patient is getting tired. If they are breathing really hard, then you're already diagnosing or prognosticating your rate of exhaustion for this patient. In addition, now you want to again touch or feel your patient. And here we are palpating for the trachea, and Andrew, I think you show us palpation of the trachea, but it's in here, it's in the middle, using your 2 fingers, and you're trying to use the middle to feel whether your trachea is in the center there. Look for distended neck veins, and usually we can see this, whether they're, especially when they're sitting up semi-recumbent, like at 45 degrees, you might be able to see, what we call the distended jugular venous pressure, or just engorged neck veins. They normally don't have that. And check for chest trauma. You will have to feel, like we said, palpate the patient. And again, as you feel, you're checking for expansion. Is it equal? Is one side actually moving and the other is stationary? We shall demonstrate. And in all this, of course, you've already attached your pulse oximeter, so your SpO2 comes in handy. SpO2 gives us, the pulse oximeter gives us both the oxygen saturation, but also the pulse. So remember we said cardiovascular is part of the parts that might affect breathing. So that pulse might tell you that your patient is compensating or not compensating enough to their hypoxia. And eventually you listen, and you want to listen to air entry. Is it your normal bronchiovascular breath sounds? Okay, of a normal, someone like you sitting in this room. So go back home, put a state on that chest and listen to those normal breath sounds. If you know the normal, you will identify the abnormal better. Are they equal bilaterally? If they're unequal, is one louder or it's just reduced, or the other side is just reduced? So again, the normal will guide you. So if they are reduced breath sounds, usually you're worried about a mass or excessive air, a pneumothorax. So, and shall see interventions for that. And that's when your percussion comes in handy. If you're hearing reduced breath sounds on one side, does it sound like a drum? Okay, if I percuss, is it very loud or I hear nothing? So very loud and reduced breath sounds when listening with auscultation equals excessive air in your lung, pneumothorax. If it's dull on percussion with reduced breath sounds, then it could be a mass of fluid. So we are listening to check out. And then you also listen for added breath sounds. So we call them crackles, some people call them crepitations, some people call them rails, but it sounds like you squashing a cavera. I hope, and you know a cavera, a plastic bag. So if I squash it, that feeling, that is what crepitations sound like if you listen. So those are not supposed to be there. So if you hear them, then you're worried about fluid in the chest, like pulmonary edema. And then wheezes. We said wheezes come up in lower airway obstruction. So your bronchioles, now we are down there, they are obstructed from mucus, from just collapse of the bronchioles, like in asthmatics. We are worried about that. And then we've already talked about feeling for the chest wall. So in addition to your primary systems, which is the airway that we talked about and breathing, we also want to listen for any other causes. I mean, look for any other causes that might be causing our patients to be decompensated. So one of these places is the heart sounds. So you're already very close to the chest. You can't listen to the breath sounds and not pick out your heart sounds. So go ahead and listen to the heart sounds. And if they are muffled and your patient is really hypotensive, they're tachycardic or irregular, have irregular heart sounds, already wondering, is this because of decompensation in my airway obstruction process? And then check out their BP and heart rate. And again here, heart rate, we want to count for 1 minute. But because we are emergency care providers, usually we say 15 seconds is enough for you to count and feel the volume and feel the rate. And here you're looking for signs of shock. Is my patient cold? Do they have a pulse that's over 100 or below 60? Are they Bradley or tachycardic? Then check your GCS. And the quicker way, GCS is very detailed. So we usually use AVPU. So check if your patient is alert. If you called Daniel and they responded immediately, then they're probably, or even before you call them, their eyes are wide open and they're willing to speak to you, then that's alert. Check out the verbal. If you call their name and they responded, if you reached and they were not responsive and then you call their name, then they are responsive to verbal. And then check out if they are responding to pain. And that is us applying stano, a stano rub, check out response to pain. And then if they're unresponsive, totally. So that's your AVPU score, and it will help you know if your AVPU is A and B, response to B, then their GCS is fairly good. But if it's P and U, then most probably their GCS is low, below 8. And so those are people with airway, obvious impending airway obstruction. And lastly, you have to expose your patient. We talked about anaphylaxis. So you want to look for signs of rashes, or swellings on the rest of their bodies, like bumps, if they ate something or something hit them, if they are bee stings, are they diaphoretic? Do they have stroma to the chest, maybe it's penetrating to their chest, or limb swelling that's telling you that maybe there is risk for complications of DVT that may lead to your oxygen problems, and then check pulses in both limbs just in case. Yes, thank you very much. I will invite Sonia to take over next.
Thank you so much, Dr. Krishna, for that presentation. And I believe all of us are in attendance.
Okay, perfect. Thank you for the initial assessment for airway and breathing for general adults. And just to go over some pediatric specific considerations in the assessment of someone with threatened airway. The first is just your general appearance of the patient. It is similar to adult emergency care as well. We want to know their work of breathing. We have something called the pediatric assessment triangle. That is one way of remembering how to just see a patient from the doorway of the room. The first is the blue triangle. We see appearance. We want to know what is the tone of the child. Do they interact with you? Are they just crying and in severe distress? And then you want to also have an idea if they're alert or not, if they're looking at you while you're examining them or engaging with them. This other part, the green portion, work of breathing, I think everyone can understand that easily, but you do want to see in children, the work of breathing is more easily observable compared to adults. Often in younger patients, infants especially, they may have head bobbing because of their neck muscle use for breathing. You can see retractions or recessions more easily on the chest. Nasal flaring also seems to be common in children. Of course, gasping would be more severe. And then lastly, when a child appears and you want to assess them quickly, you want to also see their circulation. Are they pale? Are they having poor pulses? Those are all very worrisome features. Next slide, please. Thank you. So these are just pictures showing examples of, in this blue triangular area, here is an example of a child with poor tone. That this is just showing an examination, but if a child usually is developmentally able to sit on their own and they look like this and limp, that is a bad sign. Over by the green triangle, this is just an example of recessions, breathing hard in and out. And then in the red, the bottom of this slide, here accompanying the red portion is just an example of central cyanosis, where the lips are looking blue, which is also a poor prognosis for the patient. Next slide, please. So some other considerations for a pediatric patient, there are some different anatomical features that you want to think about when you're taking care of children. So compared to adults, they have a larger head compared to the body size. So this will impact your positioning of the patient when you manage the airway. The same thing, the ratio of the tongue inside the mouth is also larger, so it is more crowded inside the mouth to be able to, manage the oral airway. Of course, their airway is also smaller as a smaller patient, and then it is also more anterior compared to adults. Next slide, please. And so as was mentioned earlier, in adults, the respiratory rate, a normal rate would be somewhere in the range of 12 to 20. In children, it of course changes by the age. And of course, the youngest patients, infants and neonates, their respiratory rate could still be normal up to 50 breaths per minute. But as they get older, you'll see that the respiratory rate should decrease with the age. And so this is just one table. You don't have to remember all the numbers, of course, but it is a reference guide just to keep in mind when looking at a pediatric patient. So for those, you can always take a screenshot of this, or usually online, there's a reference for the vital sign respiratory rates. Next slide, please. So this slide has a lot of words, but the main thing is just to compare some different features of the pediatric airway and how it impacts their breathing. So these are the unique features of the pediatric respiratory tract compared to adults. So just going from top to upper airway to lower airway, the first starting with the nose. As people say that infants usually under 4 months of age, they do prefer to breathe through their nose. So this means, as a consequence, if they have nasal congestion from bronchiolitis or a respiratory virus, this can actually already lead to some respiratory distress, which we see commonly with babies. Then the larynx, which is the also part of the upper airway, it is much more soft compared to adults and more elastic. So as a consequence, if you consider intubating a child, this means that their airway is also more collapsible. So you just also want to be mindful of that. Then going down the airway some more, still in the upper airway, the trachea, it's important to know that for children, the trachea is shorter and also a much narrower diameter compared to adults. So because of the shorter airway and the narrow nature, this means that as a consequence, if you use an endotracheal tube, the ETT, that means it's easier to dislodge. And you also want to use a narrower tube, of course, and we'll talk about tube sizes later in the interventions. Going to the lower airway, the alveoli, the sacs for exchanging gases, they're less developed in children, so they collapse more easily as well. So this can also lead to issues with lower airway infections. Of course, the lungs in children are smaller capacity, their chest wall is more compliant, and the muscles are more immature. So overall, children just have less reserve than an adult and may tire more easily when they have a respiratory illness. So this, next slide, please. Here is just one picture of an example of a differential diagnosis when you're assessing a patient and thinking about possible causes for their respiratory distress. I won't go through all the the details of each illness here, but one way of thinking about the differential diagnosis is just to think about upper airway or lower airway problems. The pediatric, very specific ones typically include a retropharyngeal abscess in the upper airway, peritonsillar abscess, foreign bodies common in children, and laryngomalacia is usually a pediatric condition when infants have a very soft, immature larynx. It makes it easy to have some noisy breathing. And then those are the lower airway bronchiolitis is typical for children. And those are really the ones I wanted to highlight. I think those are the key pediatric assessment considerations. And I think we can move on to the next slide.
All right, hello everyone. So this is Andrew again. We are going to go through some of the airway interventions that the Rapid React teams or any of you can do when you find a patient with either an airway or a breathing obstruction or some other problem. So you've heard how to assess these patients. Now, what do you do when the team you're there and you're responding to them. So we'll just kind of go through, if we can zoom out to show the projection, and then Dr. Olinga and Sylvia will help demonstrate some of these interventions for us. Before we get back to the PowerPoint. Okay, so when you first respond to a patient who has signs of respiratory distress, one of the most obvious things you're going to see is if they're choking or not. For the adults, they'll often have the universal choking kind of sign, which looks like this, and you don't hear any air moving. For pediatrics, it may be a little less obvious if they're choking, but sudden onset, inability to move air, and cyanosis and other things can lead you to suspect they may be choking on something. So for adults, the best intervention you can do if they really can't move any air is to do the abdominal thrust, or Heimlich maneuver, for those who are familiar with it. So I agreed to let Dr. Olinga show it on me, and hopefully I don't vomit. So if I'm choking, I'm asking for even in practice, I almost want to vomit if someone does that. But what he's doing is he's taking his thumb like this, and then his other hand over, and then pushing up under the xiphoid process, and then going up. So up pressure, lift the patient, lift up towards you, because you're giving them a hug, and then just doing that. You do that 5 times to see if they can expel the object and start breathing again. If that doesn't work on adults, then you can use the back slaps. And actually, I'm going to show that on YouTube if I can get some revenge. You can try to do back slaps 1, 2, 3, 4, 5. If that's not working, then you can go back to the abdominal thrusts. And you do these until the object comes up and they start breathing again. If they lose consciousness, then you got to go down more the CPR route. But so those are the initial things. Then for infants, it's going to be slightly different. So for infants, you want to start with the back slaps. And Sylvia is going to show us how to hold the baby while you do the back slaps here. So she's holding the baby on her arm and then delivering back slaps kind of just below the shoulder blades. You do 5 in a row to see if the infant will pop out whatever's blocking the trachea. And then if those 5 back slaps don't work, then you flip, baby's still on your arm, and then you deliver 5 thrusts just to the lower part of the sternum. So 5, see if the object is expelled. If not, then flip back and go back to back slaps. Good. And then for the child, yes, if they go unconscious, then you go back to the CPR like you would in adults too. Okay, this is just a poster for the CPR. We've already gone through this, but if we can share the slides afterwards, then you guys can use these for your reference, or they can easily be found online as well. That's showing the same thing. Okay, so the other thing is foreign body removal. So when you do those kind of interventions, perhaps the object will pop into the child or adult's mouth. If you can see the object and safely take your finger and sweep it out, then that is acceptable to do. So only if you can visualize it. If you can't really visualize it, or it seems way deep down in there and you try to stick your finger in to get it, you can push it into the trachea and actually make the problem worse. So we don't tell people to do the blind sweep anymore. But if it's past the pharynx, past the area that you can see, the patient will likely need a specialist to kind of help. So that can be an emergency doctor, an ENT, a pulmonologist, someone who can look possibly with a camera or an intubating blade, and then use clamps to remove it. But if you go for it blindly, you might push it into the trachea and make everything worse. But you can remove things in the mouth. So hopefully that is clear. And then another, so we're past the choking stuff. This is a patient that you see that seems to be having blockage of their breathing or inadequate breathing. One of the first things you're going to do when you respond to that patient is make sure that their positioning is good. So for an adult, and actually really anybody, often if they're laying down, they can obstruct their airway. So you tend to want to get them sitting up, like 45 degrees or more. So have the patient sitting up a bit more, see if that opens things up some. And then in the unresponsive patient with noisy or inadequate breathing, you're going to want to position the airway a bit better. So one of those things you can do is the head tilt chin lift. So Dr. Olinga will show us how to do that.
So I'll place my hand on the forehead. Then the two fingers will just be at the chin. So I'll be tilting the head while lifting the chin.
Okay, very well done. Hopefully that's clear. Yes, you're pulling up on the chin, pushing back on the head. That's good if there's no worries about the patient's spine, especially. So that's usually the one you're going to do. For any patient you're worried about their spine, like a trauma, so you don't want to be doing that so much, you can do the jaw thrust. And this is the one I tend to do more. And for this one, you want to put your fingers, I usually use 2 fingers, put them behind the mandible and then thrust forward. And you'll hear someone who's like snoring, very noisy breathing, you just do that and things open up right away. So if you want to show us how to do that, Sylvia. It's actually hard on the mannequin because the mandible's not movable, but yes, you behind the mandible and you pull up till it opens up. And this often will open the airway for you. Okay, and then I was going to have Dr. Sonia tell us kind of about the positioning for the pediatric airways, especially if you're able to.
Yes, sure. So just like in adults, you also want to make sure you have a good alignment of the airway. The picture of the patient on the left side of the screen, I believe that you're seeing, is an example where you are just having the patient lay on the stretcher. You can see they have a bit of their neck is tucked in, and that would make a difficult passage of the endotracheal tube if you're trying to intubate them, because of the angle of the airway. So the best thing, because of the larger head of the patients, you can use both a head, a little bit of a head roll, or with a shoulder roll. Shoulder roll is typically the most common thing to use to better position the head so that the airway is straight. And you may consider that the ears of the patient want to be kind of in line with like their shoulders almost.
Good, thank you. So yeah, that is how you're going to position, because if the baby's laying flat, the airway can likely be blocked. So good information there. So this is the positioning of the patient, whether adult or pediatric. Another thing you're going to do when responding to some of these cases is to suction out the airway if they have any evidence of secretions, if they have gurgling sounds or they're vomiting. So you're going to want to suction. In an awake patient, you can do oropharyngeal if they let you, but if they're clenching their mouth and won't let you suction, then you may have to go through the nose, and you can suction that way. And I think we all do this all the time in our hospital, so we know the importance of suction. So that's a good way to clear anything in the airway. So after positioning and suctioning, an oropharyngeal airway is another important adjunct you can use. This is for patients who cannot keep their own airway open. So whether they're comatose or something else, their tongue is blocking their breathing. And you can't do the jaw thrust forever on these patients because you have to stand there the whole time. So the oropharyngeal airway is a way to keep that open without having to do the jaw thrust. It's maybe a bit too bright on the screen, but this shows the different sizes of the oropharyngeal airways. And it's important to get the correct size for your patient. So it should go from the incisors all the way down to the angle of the jaw. And then for the pediatrics, what do we say? From the lips to the earlobe should be the size of the oropharyngeal airway. Inserting the oropharyngeal airway, you have to practice doing it once.
It is those 36-hour shifts.
So to insert the oropharyngeal airway, I'll actually grab it. So you actually go in, this is kind of counterintuitive, you go upside down with the end of it pointed toward the pallets. And once you're past getting resistance, then you actually flip one, and that puts it behind the tongue. So Dr. Olingo is going to demonstrate oropharyngeal airway insertion.
So I have various sizes with me, and like Dr. Andrew said, I have to measure to actually get the correct size for this patient of mine. So I'll take one of these, and it should be really quick. And yes, the incisors to the angle of the jaw, and this might not fit. So incisors, angle of the jaw. So I think this is the right one. Lubricate it so that you get in smoothly. So you have KY jelly in your centers and in your wards. So I gently insert it with this edge like Dr. Andrew had described. When I reach the resistance, I turn it 180 and advance it further for it to sit behind the tongue. Then I can support it with the lips. So there you've supported your airway, and you can do any other management.
Yeah, very important to get the correct size of oropharyngeal airway and just to get it behind the tongue, because that's what's going to keep the posterior pharynx open. So it's a very good adjunct to have and important to know how to use. In a patient who is clenching their jaw and won't let you put in a oropharyngeal airway, another option would be a nasopharyngeal airway. So this one, again, also very useful. You can't do it in people with any suspicion for fractures to the base of their skull because it might go into the brain, but in people with no nasal bleeding, no severe head trauma, it can go, you put lubrication and insert it in one nostril, and that can actually open up the airway too while you're bagging them or whatever else you're doing. So if you want to show us insertion of the nasopharyngeal airway.
We are going to insert the NTS or the nasopharyngeal airway. You have to also turn the right side of the patient where you measure from the angle of the nose up to the angle of the earlobe. Turn into a fit. So I think this one has fit. This one is small. The idea you have to replicate it. You can use your KY or you can use Vaseline sample. Yeah. You lubricate it and you push it the way it is, the way you push it this way for the oropharyngeal airways. So we are inserting it the curve facing upward. But for the nasopharyngeal airways, we go the way it is. We go the curve facing downward. And when you feel the resistance, now when it's really started, there will be no resistance and it's free, it sits at the top of the nose. You can secure it that way and open your airway.
Good, thank you, Sylvia. So that is nasopharyngeal and oropharyngeal airways. Again, great for opening up the pharynx, especially in someone that you can't jaw thrust for an extended period of time. And so a more advanced thing we can use would be the extraglottic devices. Now these include the laryngeal mask airways, as well as the king airways, which are fairly rare to find here, but laryngeal mask airways we can use pretty often in our hospitals. So the idea with the laryngeal mask, it doesn't go into your trachea or vocal cords, but it sits just outside of them. And then you blow up the seal with air, and then that forms a tight fit on top of the glottis, and really helps air go directly into the trachea instead of into the esophagus. Go back to when you insert it, this is a patient who most likely is comatose because people can't handle it if they are awake. You use it as a bridge to intubation. So you can't have someone permanently on a laryngeal mask airway because it's not completely protect the airway. They can still vomit through it. So it's not definitive, but you use it as a bridge to intubation. It does improve oxygenation and ventilation. It's really good to use actually in cardiac arrest patients when you're doing CPR because you don't want to interrupt CPR to do the intubation usually. And you can do this very easily while CPR is ongoing. So I think it's probably the best thing to use in a patient getting CPR. But in a patient who needs intubation, this is not definitive and you have to then intubate the patient if they need it. So here's an example of the LMA and where it goes. So if you guys can see that, this LMA is just sitting on top of the vocal cords there and pushing air directly into the trachea. And then we'll show you how to insert it. I'm gonna go back to that. So to insert the LMA, Dr. Olinga, if you want to show us the technique.
All right, like the previous devices we had before, we still want to get the right size for the patient. So for the LMA, the sizes are actually labeled according to the weight of the patient and always ensure that it's actually functional. So you have to test that this seal can actually hold air when you inflate it. So all of us have pens and we use pens every day, you know, office, even right now. So if you have a pen with you, you can actually insert this LMA with me right now. So hold your LMA like a pen and you usually write just like this. So this index finger is close to this seal so that it gives you that firm grip as you're getting in. And the curved part goes through the hard palate. So as you're holding your pen together with me, we shall get into the mouth and then advance. So this index finger is helping me push. So when I reach resistance and my index finger cannot go further, I gently apply more pressure to just push it to the oropharynx so that it sits behind the tongue and in front of the trachea. So after doing that, I then inflate my cup. Again, the volume of air that you desire is labeled here. And in this, I have about 10 to 15 mils. So I inflate. And with that, I know that there is a firm positioning of my LMA and I can then continuously bag my patient.
Well done, thank you for that demonstration. So again, a great adjunct to use during a CPR during cardiac arrests. Another one, if you guys have access to it, would be a King Airway. These are used very commonly in the field, like paramedics or people who have the ability and have to transport the patient. It's not a definitive ET tube, but it does protect the airway more than the LMA. So it has this balloon below that goes into the esophagus and somewhat stops vomit from coming up into the airway. This balloon is above, and between the two, the air comes through here and directly into the trachea. So we talked about ways to keep the posterior pharynx open, extraglottic devices, positioning, other medications you should be giving during an airway or breathing emergency. Certainly, if there's any signs of anaphylaxis, giving adrenaline. 0.3 is usually the dose for adult patients. It will be weight-based dosing for pediatric patients, obviously. Steroids for any signs of allergic swelling, or even infectious, like with epiglottitis, croup, any of those, I would also be giving steroids for that. Antihistamines if there's any sign of an allergic component to it. And then depending on the condition, other medications or surgical interventions may be needed. Ultimately, if you are having signs that the airway is being closed off despite what you're doing, or if it's rapidly progressive swelling, If the patient is comatose and cannot protect their airway, then you do need endotracheal intubation. So you need to protect that airway. So indications, again, if the patient can't protect their airway, they're an aspiration risk, then intubating them would be ideal. Or if there's any risk of obstruction from infection or swelling, like we've talked about in this case, then intubating as soon as possible before they lose their airway is important. Indications in breathing for intubation is if they have failure in oxygenation or ventilation and your other treatments and medications are not helping. Disadvantages of intubation: it is a difficult procedure, so you do have to have specific training for it. It does stimulate the pharynx, so people can vomit during it. It does require a high level of hospital resources because you need a ventilator, you need an ICU. So we can't do it as much as we'd probably like to. But in cases where you really think that is what's needed, then that is what should be done. So then Dr. Sonia was going to tell us just a few specific things about pediatric intubations.
Sure, thank you. So for pediatric endotracheal intubation, there are two considerations. One is sometimes the laryngoscope blade that you'll use. For younger patients, you can use either something called a Miller, which is a straight blade, or a Mac, which is a curved blade. Usually for younger, smaller patients, you would consider using a straight blade. This blade is narrower for their smaller airway and also helps get the more anterior airway. And then the curved blade is used for older patients like an adult. For pediatrics, we also consider the tube sizing. There is a formula in this picture for calculating the endotracheal tube size. So for a cuffed endotracheal tube, we usually have the age of the patient divided by 4. Then you add 3.5. It's a lot of math to do in a short time. But then for the uncuffed tube, you use age divided by 4 plus 4. And this uncuffed tube we usually use for neonates and younger patients. And the cuffed tubes we use for older pediatric patients, like above the infant stage.
Good, and then I think also comparing the size of the ET tube to the patient's pinky is another method you can use if you can't do math in the moment. For adults, small adults, like a 7.0 tube is usually okay. For very large adults, an 8.0. Most people end up getting a 7.5. But yeah, those are, if you get training in intubation, that is something that can be done. This I'm just going to briefly mention. This is so for the patient that you cannot intubate, whether due to swelling or some other problem, you can't pass the tube, and then you can no longer bag indicated. And this is where you surgically cut over the cricothyroid membrane, which is just below the thyroid cartilage. Again, this is something you need specific training in to do, but I'm just mentioning it so you know what happens if we can't intubate in some of these cases. And then just for time, we're going to move past that one, but maybe we can share the slides with you. So then interventions for breathing, these you're always going to start with some oxygen, right? So your goal oxygenation is 92 to 99%. For COPD specific patients, you maybe want it more like 88 to 92. Avoid too much oxygen. So supplemental oxygen, so either by nasal cannulae, non-rebreather, etc. You do not want them saturating 100%. You want them 92 to 99%. Because if you're going over the 99, you can actually cause long-term damage to them from too much oxygen. So only add oxygen if they are below that 92%. Sometimes if you can't get a good reading on the pulse ox, which happens a lot, and they're in respiratory distress, I'll still add oxygen even if I don't know. But if you get a good reading and it's above 92, they don't need more oxygen. So this is the fundamental between a lot of our interventions is adding this oxygen. The lowest we can go, and I know this is all a reminder for everyone, kind of basic stuff, but nasal cannulae, 2 to 6 liters per minute. It should be humidified or else it's going to dry out their nose, cause nosebleeds, etc. This only gets you up to oxygen FiO2 of 40% if it's up to that 6 liters. So it can't get very high on the FiO2, 24 to 40%. It's also limited if they're a mouth breather, if there's any obstruction in their nasal airway, then it won't really help. But this is often the basic one that we will start with. A simple mask, if you can't get their saturations up with the nasal cannula, you can use a simple mask. This one should be done 5 to 10 liters per minute. It shouldn't go above the 10 or else you're not really giving them any extra benefit. This will give you an FiO2 of 30 to 60%. You shouldn't go below the 5 either. If you have it on 2 liters a minute, then you're probably actually blocking their breathing. So it has to be at least 5. And then the non-rebreather mask, this one is for people who are just saturated really poorly despite the other types of oxygen. This flow needs to be at least 10 liters, and the bag has to be inflated. If it's below 10 or you see the bag deflated, then you're actually blocking their breathing and you're causing more harm than good. So at least 10 and up to 15 is the standard. This can get you almost to 100% FiO2. So in the severe oxygenation problems, this is often what we end up using. Yep, I think we're going on generator. Well, they don't get the projection. Share screen from my PowerPoint. One second, guys. Share screen from PowerPoint until the projector turns back on. All right. Okay. So we can look up there for the rest of the presentation until the projector comes back on. Another thing I wanted to mention is high flow nasal cannula. Now, this may not always be available, but has been really helpful in response to COVID, because you can get up to 60 liters per minute without causing the patient harm in their airways. And it gets you up to 100% FiO2 and does actually give you some pressure. So if they have a hard time keeping their alveoli open, that pressure is going to help. Okay, next slide. Another thing I'm briefly going to mention is non-invasive positive pressure ventilation, and this is BiPAP or CPAP. This one has really become a lifesaver in a lot of conditions. It's really good for COPD asthma if the patient is tiring out or has respiratory distress. It's also really good in pulmonary edema with congestive heart failure patients because it helps push the fluid actually out of their interstitial spaces. So it's really ideal for those three. It can be used for other things, but those are the top three, I think, to use it for. The problems with it is it's very uncomfortable for the patient. So if they've never had it before, they often can't handle the pressure from it. They have to be talked through it or given Ativan or something else like that. So it's difficult on the patients, even though it helps their disease process. You also can't use it if the patient has a lot of secretions or vomiting or if they have altered mental status, because it can actually be dangerous in that for those cases. So specifically asthma, COPD, CHF, I think this is a really good adjunct. We actually have it in our AD or in our ED. So if we find some good cases for it, we do use it. I'd actually just keep doing this. So then another adjunct is a pediatric bubble CPAP. This can be used with just an oxygen concentrator and then something with fluid, like a Renzori bottle with fluid. You cut the nasal cannula, you put one end in the fluid, and then the other end goes to the oxygen concentrator. So some of you may already be familiar with this, but it actually provides some pressure for infants. It can't be used for anybody older because It's not quite strong enough, but for infants, this can specifically work. Another very important one we want to get across is proper bag valve mask use. So this is a lifesaver in people for temporary use in patients with apnea or inadequate respirations. It's used as a bridge to intubation. You won't usually get somebody from bagging to back to like a non-rebreather or something like that. It's usually a bridge to intubation. It assists with both oxygenation and ventilation. The downsides, it does not secure the airway, so they can still vomit and aspirate. It can't be used if the patient is awake because they can't usually stand it. There can be problems with getting a proper seal. So if the patient is really obese or has a lot of vomitus or like a beard like mine, then it's hard to get a good seal with the bag masks. So there are some downsides that can be used in a patient that you're planning on intubating. So we are going to show you the techniques for doing the bag valve mask. So if you're a single person doing the bag valve mask, the method is the C and E. So you make a C with your thumb and index finger, and then an E with your other 3 fingers. And then Dr. Alinda is going to show us how to do this on a single provider.
So this is the mask and the amplifier. So this rests, the apex of the mask rests at the nozzle bridge, then the base rests at the chin or the mentor. So you join them together and you form the bag valve mask. So for one-man technique, you create the C, which rests above the mask on the hard part. Make sure your mask is well inflamed to rest on the cheek of the patient. Then the E is to mimic opening of the jaw, all right? So you place it gently, then open the jaw, so jaw thrust, right? So that all things open. Then you can carry out your bag mask ventilation, okay?
Good, and then so that's one person. So the C to E method, getting a really good seal on that. Your seal is going to be even better if you have 2 people, then you can do the 2-hand technique. So they're going to show us how to get a good 2-hand technique. If you guys can work together on that.
As you said, how Dr. Dan has explained, you make this, the apex rest on the nasal bridge and the base rest on the cheek or the mentor. And you have to make sure that you have the right size. Don't get a pediatric and put it on another direction. Then you fix it, make your sleeve. And you do that part.
So with the 2-hand technique, you Okay, hello, hopefully everyone's still there. Sorry, our internet went down, so we are back. Can everyone hear me okay?
Yes, we can hear you.
Thank you. So Dr. Chizito is going to add something for the bag valve mask technique.
So what I was saying is that as we use the bag valve mask ventilation, it's very important to watch out for chest rise because sometimes you're not aware that you have no seal. So maybe watching out for the rise of the chest is what will show you that your air is actually going in. But even so, and even while at it, it's important to bag at the correct rate. You should not just, you're just pumping in air. So rate and volume of your bagging are very key for bag valve mask ventilation because you risk actually rupturing barotrauma, rupturing the patient's alveoli if you pump in too much pressure. So you're supposed to squeeze half that bag for an adult, not all of it in, because your tidal volume is actually just 500, half a liter is what you need as an adult. So don't squeeze in the whole bag at once, just squeeze halfway and at a rate of about 12, what your normal respiratory rate should be. So every 3 seconds, you're squeezing in something, breathing, or as slow as the patient is breathing, because you're trying to make them catch up on their saturation, basically. Exactly.
Okay. And so final intervention for breathing is going to be intubation again. So for those same indications that we talked about in the airway section. The other important thing with the intervention for breathing is to treat the underlying condition. So if it's pneumonia, give them antibiotics. If it's asthma, COPD, they need steroids, bronchodilators. Pulmonary embolism, give them some blood thinners. If it's heart failure, nitro, diuresis. Pneumothorax needs a chest tube. Pleural effusions, you can do thoracentesis. Tense ascites, you can do paracentesis. Tamponade pericardiocentesis, so draining the fluid from the different areas. Opiate overdose, give them naloxone. So you're treating the underlying condition while also trying to control the airway and breathing. So that was it for interventions. I was going to briefly talk, if we have time, about some of the specific airway emergency conditions that we discussed in the differential for this case. So just briefly, for angioedema, this is something that causes rapid swelling of the lips, the tongue, can even swell the uvula or the epiglottis. It can be hereditary, actually, so some families will have this and they just get at random episodes of it. It can be from allergies, or it can be non-allergic reactions to medications like ACE inhibitors. It often becomes an airway emergency if the tongue or epiglottis are involved. Sometimes if just the lips swell and it stops there, then it does not turn into an airway emergency, but if the tongue starts swelling, they usually need allergic mediated angioedema. We go ahead and give adrenaline antihistamine steroids. But for the ACE inhibitor angioedema, none of that will actually help. Then there's other specific medications for hereditary angioedema, but the most important thing is airway. I briefly mentioned before, so that's an infection underneath the tongue in the submandibular space, and it can rapidly airway emergency. And we see this here. I've seen a couple of cases already. This needs stat drainage by ENT to decrease that space. If they can't get quick drainage, then you need to protect the airway. So they also need intubation. And I would even plan for a crike. Get ready to do a cricothyrotomy because there's a chance your intubation won't be successful. It also needs antibiotics, all that kind of stuff as well, but airway control is the life-saving thing. Viral croup is the another diagnosis and was one of consideration in the case. This is a common cause of stridor in children less than 3 years old, and it's caused by inflammation and swelling in the larynx. They'll have that barking cough present. It's rare for it to need intubation or cause complete obstruction, but you should be ready for it if it does. Usually the treatment is, dexamethasone IV, prednisolone also could be given, cool humidified air. And then in severe cases where there's stridor at rest, then you can nebulize adrenaline. So this is one that maybe we could have nebulized adrenaline in. You have to make sure it's not epiglottitis or a foreign body, because those have a higher chance to completely obstruct the airway. And then a quick look at epiglottitis. This is more bacterial infection of the epiglottis. It will rapidly progress well, and so you have to intubate early before it becomes impossible. You can kind of see in the pictures, hopefully those are turning out. This is normal epiglottis vocal cords. In the case of epiglottitis, you can't see any of that. All you see is this big swollen thing, and you have to try to put in an ET tube through that. So usually epiglottitis, it presents, we say the 3 Ds, drooling, dysphagia, and distress. They'll also have stridor and kind of a muffled hot potato voice. So if it's someone who's like not vaccinated, do you think about this? Or in someone whose stridor is rapidly worsening, you think about this? So those people need airway control as fast as possible. I would get a specialist on board as fast as possible to control that airway. And usually it's caused by Haemophilus influenza. So luckily we have a vaccine for that. Strep and staph are also common causes. And this is just kind of going back to the treatment. You can do steroids, antibiotics, nebulized adrenaline, but they still need definitive airway control. Then we already talked a bit about foreign body. So pediatric patients, if you have sudden onset inability to move air, that's who I think about this in, or an adult who's obviously choking. Use those Heimlich maneuvers, the back slaps, and if it's visible, you can try to remove it. If it's not visible, we need someone with the scope and the skills to control the airway. And someone asked about x-rays on the group chat. So foreign bodies, you can use x-rays if the patient is stable enough for an x-ray. So that's the key, they have to be stable. And a lot of foreign bodies won't show up on x-ray. If it's food, it usually won't. If it's a coin, it certainly will. Same with croup, you can get an x-ray if the patient is stable. It will show some narrowing of the larynx. Epiglottitis, if the patient is stable, you can get an x-ray and it shows like swelling of the epiglottis. But usually those patients aren't stable enough to get an x-ray anyway. So that's kind of the use of radiology that we have for these patients. They just have to be stable enough to receive. Okay, so that is the presentation part of this and the demonstration. So if we can give a hand for Dr. Alinga and Sylvia for the demonstrations. Good, and I'll pass the mic back to Charity.
Thank you, Dr. Annie, for this presentation. And I also thank all the experts for that have assisted in the demonstrations. That was quite elaborative and educative. Thank you so much for that wonderful presentation once again. And I still take this opportunity to welcome all those ones that have logged in. And for specific hospitals, I've seen Mbarara Regional Referral Hospital that has logged in, and others as will be communicating. Right now, we welcome questions from the presentation, and we shall mainly welcome questions from the test presentation at first, then others shall be answered as they appear on the charts. So any questions from the case presentation from the participants? Okay, as we await for some questions from the participants, one of the questions that was on the chat was, and this is directed to Dr. Anna, why did the child arrest? You mentioned that SpO2, you mentioned that the child had an SpO2 of 98%. What happened in between? Dr. Anna, please. Dr. Anna, can you hear us? I refer the question to Dr. Priska. I repeat the question again. Why did the child arrest? Yet it was mentioned that the SpO2 was 98. What could have happened in between?
So as Dr. Anna tried to explain in the presentation, this child continued to have stridor despite the interventions that they used. And as we earlier mentioned, the role for your airway and breathing is not only oxygenation. 98% is equal to oxygen is getting in, but is not equal to carbon dioxide is getting out, okay? So when your airway is obstructed, either or both functions might be blocked off. So now when carbon dioxide goes up, you risk actually suppressing the rest of your body. We call it carbon dioxide narcosis. So it's like you're poisoned with carbon dioxide, and you can as well go into a cardiorespiratory arrest, which might explain why this child ended up crashing.
Yeah. I was going to add too, I have a little bit of suspicion that this might have actually been an epiglottitis case, because the child did not have all the vaccines, and the rapid progression from statin, well, even with some stridor, to an arrest makes me think maybe it was something else other than just croup.
Thank you, Dr. Andrew. To Dr. Priska again, someone on the chart needs to know why powerful anti-inflammatory agents were used, and he also wants to know, would it be relevant to use the steroids, or are they contraindicated?
So for our case, what we actually used was paracetamol, because this child had a fever and of course inflammatory process. They also nebulized with some epinephrine because it's useful in patients with stridor, like Dr. Andrew mentioned in the interventions, and then oxygen and ceftriaxone, antibiotics, because I think they believed it was an infectious process. So I don't think those are very powerful anti-inflammatory per se. I think they're actually appropriate for the case. And yes, steroids were actually the additional intervention that we had hoped to add in this case. So dexamethasone IV would have been a useful addition, or even methylpred if we had, yeah.
Another participant wishes to know your tube. How are the secretions in the tube is managed, and this goes to Dr. Linda.
So once the nasopharyngeal airway NPA is inserted into the nose, so as the patient is breathing, some of these secretions evidently come out from this opening. So you can gently insert your catheter through this opening and suction out, right? So it is safe because it's directly into the laryngeal space. So it's safe for you to suction out. And then any other that are in the mouth or the alternative nostril, suction out what you see.
Thanks.
And just to add, many a time we think we are actually suctioning, but we are probably not doing it right. Your suction catheter or yanka, I think that's the correct term, a yanka, the appendage we attach to the suction tube, usually has holes. And sometimes people just insert the suction catheter waiting to see that anything is coming up. But you're actually supposed to hold the holes on and off, so as you pull out, and that way you're able, even if that nasopharyngeal looks very small, it will still pull out whatever it is that is lower down in your airway. So just using it correctly and using the appropriate size of the catheter.
Okay. Thank you, Dr. Pista and Dr. Andrew. Right now, I wish to communicate that the post-test will soon be posted, and still I encourage the participants to do the post-test and submit it as we continue with the question and answer sessions. As we are still waiting for the questions from the participants online, still we continue with the questions that are already in the chat. Another question directed to Dr. Andrew. Someone is asking that why would you humidify raw flow oxygen of 2 to 4 liters? Isn't the risk higher than the benefit? Thank you.
Yeah, I saw the question. If you're at like 2 to 4, then maybe it's okay not to humidify. I don't see a lot of risk, especially if you're actually using clean filtered water. But certainly if you're getting above that, lower than that, it probably doesn't matter too much. Should we take any questions from in here?
Yes.
Audience?
So right now, we invite all the participants, those physically present and virtual live. Please feel free to ask any questions. We have the experts here, and we get the answers right away. Any questions from the participants here?
I remember the presentation about metrics. They say their airway is more
So Dr. Sonia, we had a participant here asking about, she wanted some clarification on the more anterior airway of a pediatric patient.
Great. So just to provide some more information about that, basically the airway of the pediatric patient as they're growing, it's just basically more forward in their throat. So when you go to intubate them, for example, you may have to look more anteriorly. So when they're laying down, anterior compared to the adults where their airway is larger and grown.
Yeah, so it's like further this way. So when you're trying to, it may be difficult unless you see a video of the demonstration, but when you're intubating, it's going to be higher up. So it's actually harder to find, usually harder to see.
And for those that intubate,
correct,
you don't insert because for it it's closer and more at the front. So you're just going anterior instead of deeper. So you don't need deeper here. Okay. Thank you, Dr. Sonia, Dr. Pista. Right now, we still welcome other questions. Any more questions? Our participants online, please join us. We are welcoming questions about this session. Now, any contributions? You're welcome. Okay, so please be informed that the pretest is already projected. And let's be able to do the pretest. At this moment, I would wish to thank everyone that has attended this ECHO, and also I thank everyone that is behind this ECHO program in a special way. I thank the Ministry of Health, I thank Seed Global, and I thank the administrators of the hospital for giving us the chance, and Mbarara Regional Referral, and Mbarara University of Science and Technology for this chance. I thank each expert for the time they put in, and all the knowledge that I've shared and skills. And I thank each and everyone who has taken the time to be part of this session. At this moment, I take this opportunity to welcome Mr. Alan Suga, who is from SEED Global Health, and I welcome him to talk about React teams.
Thank you so much, Sister Charity. I'll also add my voice to Sister Charity in thanking everyone who has made it for this session. Specifically, we wish to thank the administration from Mbarara Regional Referral Hospital, as well as Mbarara University of Science and Technology, for giving us this opportunity to host this eco session. In addition, I also want to thank all our experts, that is Dr. Priska, as well as our moderator, Sister Chara Sonia, Dr. Andrew, as well as Dr. Daniel and Sylvia. Thank you so much for sharing what you've shared with us. It is exactly in line with what we stand for as SEED Global Health. We are about sharing knowledge, as well as building health systems and saving lives. On behalf of our country director, SEED Global Health, as well as Dr. Marion, the Principal Medical Officer at Ministry of Health, Emergency Medical Services Department, we wish to convey our gratitude to all the participants who have continuously attended this session. My role is simple: to tell you about the upcoming sessions and how they will be conducted. The Ministry of Health recommended that going forward, we use what we call the REACT model. The REACT simply stands for Resuscitation Action Teams. And in simple terms, these REACT teams are a form of a rapid response team, which will use a kind of a standardized approach in escalation of treatment, as well as services in managing patients. You may ask yourselves, why this kind of model and why is it facility-based? It's because the Ministry of Health, together with partners, are planning to use this approach to leverage the existing health workers, as well as the existing technology information to everyone, so that everyone is exposed to the same sort of knowledge and they are able to serve their patients better. The other question we've been getting about REACT has been, how can we be part of these REACT teams as health workers? Ideally, the REACT teams are multidisciplinary. They will include all cadres, such as emergency physicians, nurses, midwives, clinical officers, interns, ambulance drivers, directs, and personnel who are going to be serving at the different health units, from national up to the lowest health unit, health center tools. So the other question we've been getting, how will these teams be trained? We shall utilize this existing technology. So my words. Sorry about that. We shall utilize and leverage these existing technologies, the eco model, to cascade this information. And this will be complemented by physical online trainings where these experts will and kind of build on what will always be shared during the eco sessions. Then the other question that are always coming out is, why should I be part? such a model or such a team. It is basically a capacity building platform which will serve the world, but also to better care for our patients, and also as a form of professional development, to be part of REACT teams that are being formed as nominated to go across all the health facilities to kind of spread this kind of engagement with the leaders, and also appoint through the leaderships, appoint the various team members. So going forward, this is what the ECHO is going to be evolving into. Then the last question could be, if you're not part of the REACT teams, does it mean that you're not going to be part of the ECHO sessions? The ECHO sessions will always remain the way they are, and everyone is welcome to participate in the ECHO sessions. But like I said, emphasis will be on the REACT teams, and even the physical complementary trainings that are upcoming will also have a special focus on these REACT teams. The plan is to cascade this across all health facilities in the country. And as we speak right now, we've started with the national referral hospitals, as well as the regional referral hospitals and a few general hospitals. Later on, this will be cascaded across all our health facilities. And physical trainings will be called upon, and very soon the communication will reach you wherever you are. So thank you so much, Sister Charity, once again. And I couldn't help but notice that we had over 235 participants online. And in this room where we are seated, we are about 25, which is a very commendable sort of thing. So thank you so much. Over to you, Sister Charity.
Thank you so much, Mr. Aaron, for that clarification. Thank you so much, Mr. Aaron, for that clarification about the REACT teams. And we invite everyone around the regional referral hospitals and in those facilities where those teams have to be formed. Please feel free to join the teams. They are great opportunities, educational and getting experience during those times when we move to other centers. Please, we encourage everyone who is interested to join these teams so that we can improve patient care. Last but not least, I still want to thank all of you that have come for this session and those ones that are virtually with us. And I thank all the regional referral hospitals that have logged in. I may not be able to state the specific ones, but we shall see them as we are taking the screenshots. Thank you very much for attending. And also the private facilities, please, you're welcome, because we are all working for the benefit of our patients and also the individuals that have logged into this program. Thank you very much. And still the post test is on. I hope all the participants have participated in filling it and submitting it. And we've come to the end of this session. I hope all of us have learned a lot, skill-wise and knowledge-wise. And all of us, whether physically present or virtually present, we have got the skills that are going to help our patients out there. As we know that airway and breathing are usually first on our ABCD approach in the management of emergencies. Once again, we thank the Ministry of Health. We thank Seed Global Health for the support. We thank the administrators of MAST and Mbarara Regional Referral for this opportunity. And we thank all of you for attending. I request all of you to kindly switch on your videos, your cameras, and we take a screenshot as we come to the end. Otherwise, thank you for being part of this session. Please switch on your screens, your videos, your cameras so that we take screenshots. Participants, switch on our videos, our cameras, for some screenshots, please. Once again, thank you for attending. Please, we request you these sessions always go on every 2 weeks with very many topics which are essential in emergency care. We encourage everyone to always log in and physically attend in case it's at your site. Okay. Thanks for attending and wish to say bye.
Thank you, team. Thank you.
Bye.
Sylvia, I can see you.
Bye. Bye. See
Yes,
you.
Dr. Olinga.
Bye.